Thanks for watching today. I'm going to do an introduction and orientation to neonatal narcotic abstinence syndrome. My name is Kelly Bowden. I'm the perinatal outreach education coordinator for the state of Maine, and I'm based here at Maine Medical Center. Today we're going to go over the signs and symptoms of narcotic withdrawal in newborns. We'll talk about treatment options, both pharmacologic and non-pharmacologic, and we'll talk a little bit about substance use and breastfeeding. So first of all, I always like to start with using common language. And the newspapers and media, you'll often see something like babies born addicted. And that is not an accurate term. You want to be careful when we put labels on people because that does limit our view of people, and that language imparts meaning. And moms are often very sensitive to someone calling their baby an addict, and moms want better for their children, and they don't want their babies to grow up to be addicts. So please don't use the term addicted babies. Some language that is helpful, and you'll see Mark Moran's name on these slides. Mark is a social worker at Eastern Maine Medical Center, and we share slides back and forth with each other. The terms that we do want to use are drug exposed, and that's when a pregnant woman has ingested some licit or illicit substance. And drug affected is that the baby is somehow affected by substance use, and that the baby has a condition that otherwise wouldn't be present had the mother not consumed whatever that substance was. I use the term substance broadly to include alcohol, tobacco, marijuana, methamphetamine, opiates, the range of substance exposure. So you'll hear the term neonatal abstinence syndrome, or NAS, and that's when the baby has a constellation of clinically significant withdrawal symptoms. We call that NAS. And when there's alcohol effects, we use the term fetal alcohol spectrum disorders, and that's the group of conditions that can occur in a person whose mom consumed alcohol during pregnancy. And there's a range of effects, and there's a number of associated diagnoses with that. In Maine, we're working to shift to what's the national terminology of substance-exposed infants. Our law that mandates notification to DHHS uses the term drug-affected baby. So some more alphabet soup that you'll hear used is DAB, or for drug-affected baby, or SEI, or SEN. So it gave you the definition of NAS already, signs and symptoms. The original work was done on moms who had heroin addiction, and so that's what these next symptoms we're going to talk about. But I do like to start with which drug has the potential to cause the most harm. And so look at these three pictures and think about that. And we'll start off with the alcohol, and the Surgeon General has said that alcohol consumption during pregnancy is the only known preventable cause of mental retardation. So the Surgeon General recommends that women, if they're going to consume alcohol, that they use birth control. If they're trying to get pregnant, then they should not consume alcohol. We have seen results of smoking studies. We know that smoking in many studies has been linked to attention deficit hyperactivity disorder. There's a recent study in April of 2019 that says that up to about 20 to 25% of infant sleep deaths are attributable to smoking during pregnancy. So, really important when we're working with women who are still pregnant to encourage them to stop use. And then in cocaine, um, in the 1980s, there was a lot of discussion about the cocaine and the crack epidemic and how these babies were going to be devastated and more in a vegetative state. And so this goes back to the labeling conversation I started with, and that the crack babies that everyone said were going to be so damaged. Some of them did extremely well in school and went off and went to college and have very successful careers. And so, just another reminder that there's a lot we don't know about substance use, and to just be careful of the language that we're using. And as more research becomes available, we learn a lot more about the outcomes of these babies. So the combination of drugs that the mom takes does increase the incidence and severity of NAS. Again, broadly using the terminology of substance exposure to include cigarettes, medication-assisted treatment, benzodiazepines, SSRIs, um, anything that mom consumes. We do know that moms who have untreated addiction or inadequately treated addiction will have earlier onset of symptoms in the baby. In general, the timing of the onset of symptoms is around 48 hours after the last maternal dose. There does seem to be a difference between methadone and buprenorphine, with buprenorphine symptoms perhaps starting later than that 48-hour average. So the symptoms for NAS are grouped into categories, and the first ones I'll go over the central nervous system symptoms. The one that everyone thinks of is crying, and this is the baby that has a high-pitched cry, not just a regular baby cry. This is the fingernails on the chalkboard type of cry. It can be intermittent or continuous, even when the caregiver is intervening, trying to soothe the baby. Our sleep goal is that babies sleep for at least an hour at a time, though we know breastfed babies have other plans sometimes and may want to feed more frequently than that. The Moro reflex is the startle reflex, and that's easily checked and visualized even with the flash of a camera or flash from the phone camera. You can watch the jitteriness of the baby, the hands and arms. Tremors can occur in the hands or the feet. You can have tremors of one or both arms or legs, with or without tremors of the hands or feet. Muscle tone, so we want to look at the baby's muscle tone. And there's a few ways that you can do that. You can try having the baby flat on his or her back and try and pull them to a sitting position. You should see head lag. If you don't see any head lag, it's almost like the baby comes up as one piece or sort of stiff as a board. That's increased muscle tone. And very similarly, the upright suspension, you hold the baby under their armpits and their head should lag. If it doesn't, then you've got increased muscle tone. You might also see it in the baby who's very tightly flexed and you can't stretch out their arms or legs. Excoriation really comes from the baby trying to self-soothe, where a constant rubbing, the baby's maybe swiping his or her hand across the chin or the cheeks. You might see excoriation on the knees, the elbows, the toes, their nose. Again, they're just trying to self-soothe. And myoclonic jerks are really very rarely seen, and the best description that I've heard about this is to think about those times when you're trying to fall asleep and you feel like you're falling and you startle yourself awake. That would be a myoclonic jerk. Now, of course, babies can't tell us that that's what's going on, and that's why it makes it so hard to say that that's what is happening with the baby. And then the thing that we hope we don't see is seizures. Any full-term baby that's having apnea, we need to be assessing additionally, not just for the apnea, but to be aware that they may be having seizures. So that's something you're going to call the pediatrician about right away. Some tips to try and figure out if it's a seizure or just jitteriness. If you touch the baby and the movement stops, it's probably not a seizure. If whatever the motion is keeps going, you would be more concerned that it was a seizure. You can see eye staring, you can see rapid eye movement. It might look like the baby is chewing. You might see rowing motions of the arms, or the easiest one I think is bicycling of the legs, and it truly looks like the baby is riding a bicycle. Back arching and fist clenching are a little more subjective because some babies will do that just as part of being a normal newborn. So, not easy to tell when a baby's having seizures. The next group of symptoms are metabolic, vasomotor, and respiratory disturbances. And these include things like sweating, fever, mottling, frequent yawning, sneezing, nasal flaring, tachypnea, and previously described apnea. So the sneezing and nasal flaring and some mild tachypnea are probably all related to nasal stuffiness that occurs as part of opiate withdrawal. Adults who have been through opiate withdrawal will talk to you about having a runny nose or a super stuffy nose. And so the babies are no different. They experience that as well. The sweating you might see in their forehead, upper lip, back of the neck. Just be aware of iatrogenic causes, so that maybe somebody's overdressed the baby and we're actually causing the baby to be hot. And then modeling of the baby, you might see a marbled appearance of the skin on the chest, trunk, arms, or legs. And I compare that to when you go out in the wintertime and you don't wear your gloves or your mittens, and you look down at your hands and you see this sort of bluish lace-like pattern on your hands. And that's what modeling looks like. We talked about the nasal stuffiness and sneezing. The respiratory rate, you want to make sure you capture that before the baby gets moving and really wide awake and crying. So you may not be able to get the respiratory rate initially. You may have to wait until you've fed the baby and as the baby is quieted down. And then there's the group of GI dysfunction symptoms, and adults who have experienced opiate withdrawal will talk to you about abdominal cramps and diarrhea. In babies, we also see excessive sucking where they're trying to self-soothe. We also see that they'll call it all talk, no action, that they'll do a lot of sucking, but they really, once you give them bottle or breast, they sort of gulp and stop frequently to breathe and don't do a good job coordinating suck swallow breathing. Regurgitation and vomiting is normal in infants. You may see more of this in infants with opiate withdrawal. What we'd really be watching for is projectile vomiting, one or more episodes during or immediately after a feeding. Certainly could be considered a symptom, but definitely want to make sure that there's not something else going on with the baby as well, like a bowel obstruction. Stools for these babies may or may not be explosive. You might see curdy or seedy or liquid stool without a water ring. You might see a soft, mushy liquid or hard stool with a water ring. And then, of course, with breastfed babies, it's not always easy to differentiate a normal breast milk stool and a diarrhea stool. We do encourage breastfeeding as long as mom is stable in a medication assisted treatment program. The American Academy of Pediatrics has no restrictions for methadone or buprenorphine, again, as long as the mother's stable in treatment. We also need to make sure that mom understands that even if she breastfeeds, that the baby still may need supplemental medication treatment. And there's a really excellent resource for you to use called LactMeds. It's from the National Library of Medicine. And you can download it as an app on your smartphone, or you can use it on the desktop wherever you're working. It'll give you information about the safety, the impact on the baby, on a variety of prescribed, non-prescribed medications, as well as complementary and herbal therapy. So there's some barriers to breastfeeding. We'll start with mom first. So all women with substance use disorder and a history of IV drug use should have HIV testing. In the United States, we still discourage breastfeeding in HIV positive moms. There are very few psychiatric medications that mom might be on that we would discourage breastfeeding. Certainly, if there's ongoing polysubstance use, we would discourage breastfeeding then as well. Many of these moms have low self-esteem, and for those of you who've breastfed a baby, you know you have to have a lot of confidence in your ability to successfully do this. Many of the moms have a history of exposure to violence, whether it's physical, emotional, or sexual abuse, and the estimates are anywhere from 60 to 90% of moms have been impacted by that. And then the babies are tough babies to breastfeed. Some of them are really irritable. Their state lability is unpredictable. They can go from sound asleep to full on worst crying you've ever seen, and finding them in the nice, alert, ready to eat phase is not always easy. Babies are hypertonic, so that might make it difficult to get into a comfortable breastfeeding position. We already talked about their suck and swallow incoordination. They can be really hypersensitive to light and noise, and then they get this nasal stuffiness, and they get mucus on the breast, and then it creates sort of almost like a suction where it makes it really hard for them to, again, suck, swallow, and breathe. They may have vomiting as part of their withdrawal symptoms, and moms can be really sensitive around that, think that there's something wrong with their breast milk. And then these babies can do something called pull down, where it's an attempt for them to avoid stimuli and make the environment more tolerable. So they're just trying to shut everything out in order to just be a baby. So things that we see, these babies suck a lot, and sometimes everybody wants to just feed them. And so we see them getting too much formula. They're not coordinating sucking, swallowing, breathing. They have too little. And then some babies will need higher caloric density formula, but many will not. There's no evidence behind increasing the caloric density. It may be that feeding them smaller amounts more frequently may be better for these babies. So in 2012, the American Academy of Pediatrics released their updated neonatal drug withdrawal statement. They offer 3 medication choices if babies need pharmacologic therapy. Those choices are oral morphine, oral methadone, and oral clonidine. And then working with the family, it's easy to be angry towards these moms, but I think we've already brought up a few things that might help you understand how they got to where they are. Um, People say no one wakes up in the morning and says, I think I'll be a drug addict today, and that's very true. These moms have significant trauma histories and they're trying to cope with their life. Many of them are actually the offspring of people. Their parents have had addiction issues, whether it's alcohol or cigarettes or other drugs. And we've already talked about, they've had a past history of violence, physical, sexual abuse, um, and even sometimes multiple social, family, and interpersonal losses. So try and keep that in mind as you're working with these moms. In general, these moms really love their babies. They know that they need medication or they're going to withdraw, and withdrawal is scary for them. They feel inadequate that they weren't able to stop doing drugs before they got pregnant. They're powerless because they're in the medical system, and sometimes they think it's like being in a fishbowl, and none of us like that. The moms feel guilty and have a sense of failure. Again, they've often come from families who have a long line of addiction issues, and they really don't want their baby to be part of that history. So just try and be non-judgmental. Be factual. These are your baby's symptoms right now. Let's talk about how we can help you and your baby. If mom's continuing to use illicit drugs, then there has to be serious conversation about breastfeeding and the safety aspect of that. It may not be safe for her to continue to breastfeed. And then discharge planning. Is the mom able to care for her baby? Does she have good support systems in place? And the latest drug affected baby law, we have to have an infant safe plan of care in place at the time of discharge. Does she have a safe crib for her baby to sleep in? Who's going to help her? What if the baby cries a lot? Has she watched the period of purple crying? So here's the drug affected baby law that requires us to make a notification to the Office of Child and Family Services so that they can coordinate early intervention services. I just want to highlight this study about the maternal lifestyle study. You can look at it on the National Institute for Child Health and Human Development. It looked at cocaine exposed, cocaine and opiate exposed infants through 3 years of age and compared them to a non exposed group. And what they found was that there were no associations with mental, motor, or behavioral deficits after controlling for birth weight and environmental risks. So the babies who were born to moms with high education levels and high socioeconomic status did well, and babies who were born to moms with lower education levels and lower socioeconomic status had more challenges in growth and development. So this is an initial study published by Yale Children's Hospital for the new model of assessing babies with neonatal narcotic abstinence syndrome. They had previously admitted all their babies to the NICU and moved to a rooming in model, moved to non-pharmacologic treatment focus, and then prescribing morphine on a PRN dose only. Dartmouth did something at the similar timing, and they lowered their cumulative morphine dose per treated newborn. They lowered their length of stay from about 17 days down to about 12 days, and they lowered their hospital costs from around $19,000 down to about $5,000. The resource for you, the Snuggle Me guidelines were created by an interprofessional group from around the state of Maine. I'd encourage you to look at those on the maine.gov website. You just have to search Snuggle Me and you'll find the guidelines, which are now in their second edition. The bibliography for you, and thanks for listening.